who will begin by making some opening remarks and then take questions. And we also have one of the lead reviewers here, Bob Henderson, who, as appropriate, will answer some of the questions. So we'll leave you to it.
Thank you. Good afternoon. Firstly, I just wish to start by apologising to this young person and their family for the trauma and distress that was caused by the events on the 9th of March. Our staff are committed to providing patients with the best care they can. What happened in this case resulted from a case of mistaken identity and human error. I believe that the staff involved in this case were acting in good faith, but there are lessons to be learned and we will learn from them. This report is a frank read, but it is necessary to ensure that this doesn't happen again. We accept all the findings in the report and we'll turn these recommendations into an action plan, and we will have that timelines and within a week. Our top priority is to ensure that this does not happen again. Happy to take questions.
What was the medication given to the girl?
What was the medication?
Yeah.
I think in the context of the privacy and maintaining for this patient, I don't think it's appropriate to disclose what medications were given.
Can you tell me then why it's not normally given to children?
Yes, so in this case, there was obviously mistaken identity. They thought this was a young adult, a 20-year-old, and so they gave medication that would be appropriate in that setting. It's not a medication we would normally give to a young child.
Well, what are the effects on children of that medication? Like, why is it not given to children?
Yes, so there are other medications that are more appropriate for children. We have taken expert advice on this, and as from what I understand is that there is no long-lasting effects from this medication on children. It's just not the drug we would normally use in that circumstance.
What was the effect of the medication?
The medication is used to, I guess, help calm people. And so in this circumstance, they would have been calm, they would have been sleepy. But as I say, these drugs were removed from the body pretty quickly, so no long-lasting effects.
And it was administered twice, is that correct?
That's correct.
Can I just push back on the privacy issue there? Why is it a privacy concern about the medication given? We don't know the identity of the child, and obviously there's a huge public interest in this not happening again. And what has happened? Can you not perhaps reconsider and tell us the medication used?
Yeah, really cognizant of the impact of this on the young person and their family, and so really cognizant that information that comes out, people start to pull together a story. So I guess it is our decision to maintain privacy and really protect the young person and their family in this situation.
And just also, it's not the first line for adults. Why is it not the first line treatment for adults?
Yeah, that's right. So the first line treatment wasn't available. There was a shortage of that medication, and so this medication is used when the first line medication is not available.
And is it considered to be of a lesser standard than the first line medication? Why is it not available? Usually used first.
So it's available, it's used, and it was the first line medication some years ago. I guess it's been superseded by more I guess appropriate, perhaps the right term, medication.
In terms of the misidentification of the child, I understand in the first instance health officials accepted police identification only and didn't do any further verification of their own. Is this standard practice, and if so, what are the changes?
Yeah, that's right. So in this situation, the staff acted in good faith. They were given the misidentification, as you say, via the police. We do have identification policy, and that is to have two means of identification. In this particular circumstance, which was unusual, there was no identification available. The young person was unable to discuss their identification, and when we looked at the person that we misidentified them as, we had no next of kin in our health records to be able to contact them to get a further. So the staff did follow a process. It's just that there was no other identification available.
I guess if this happened again, what would you do differently?
Yes, so we've got 8 recommendations, 25 findings, and they're critical, that we pick those up and, as I say, turn an action plan quickly. I think one of the key things that we've learned from the situation is that when this misidentification happened, there was not a medical assessment done in the ED, so that you'll see as one of the recommendations. We believe that would reduce the likelihood of this happening again, and so my intention is to meet with our heads of our ED departments over the next month and to bring that into play to reduce that risk of that happening again.
How has the family reacted to all this, and have you spoken to them about how they feel about the actions that you've taken since?
So, as I say, firstly, to apologise to the young person, the family. We are actively involved with engaging with them. We have a particular person that is the key link to them to maintain that confidence and trust, and so they are speaking to them most days. We're in regular communication. We've shared the report with them. They haven't had a lot of time. This has been a much more rapid process than we would normally run, so they haven't had a lot of time to really process it, so we're just really wanting to respect their time and to work through them. There will be a more formal, we have a normal review process which we run, and so we'll be running that in conjunction with the family.
And also the woman whose identity the police thought they had taken, the woman who was thought to be this 11-year-old. What communication has there been with her?
So, I guess in a privacy situation, we have to manage those things carefully. So all I can say is that it's been managed.
Is she in the care of that facility now, or?
It's probably not appropriate to discuss that.
And how confident are you that this is an isolated incident? I know this is a pretty extreme case, but have we had incidents of misidentification before in the system?
We have, I guess, other instances of misidentification. We have patients who turn up into our emergency departments unidentified trauma and other means, and that's why we have a process to identify them. This is, as you say, this is an unusual circumstance with the misidentification leading to treatment that we wouldn't have given to this young person had we known it was them.
Among the recommendations is to create a policy, a national policy for unidentified patients. How soon do you want to see that in place?
Look, that's why we want to get the action plan sorted within a week, so that we've got very clear guidance on how quickly we can deliver. As I mentioned before, some of these things, the medical assessment by ED of unidentified patients, we think we can do that really quickly. Some of the broader things, learning from our previous national restraint policies and so forth, that's going to take a longer time, bringing the experts together to give the advice. So the action plan will clarify the timelines against that.
How was this girl restrained?
So that through our we have a restraint policy, and they followed that restraint policy, and the restraint was appropriate in the context of the misidentification.
So for those of us who aren't in the health system, can you tell us what that restraint involves?
So there are various levels of restraint. I guess what I can say is the restraint was to ensure that she was safe during the the medication being administered.
So is she held down by people? Is she strapped down?
She's certainly not strapped down.
Yeah, but held down by people?
I'm not sure I'd use that terminology, but the idea of restraint is that when you're undertaking something, you want to keep the person safe, so that they don't move, and so it's I guess the restraint was followed appropriately according to policy.
And how she was restrained? Sorry, just how she was restrained, was that when she was assumed she was an adult? Is the way she was restrained different to how you would restrain a child?
In this circumstance, as a young adult versus a slightly older young adult, the policy is the same.
The report mentioned that the girl refused oral medication and was injected instead. Was that not a red flag?
So one of the things that obviously we've looked into in the report is based on the misidentification, the assumption that it's, sorry, let's put that back. There's my hand start to go. There we go. Apologies. They can stay down there. So the assumption, obviously, that the patient was who they thought, then they followed the appropriate pathway and care. But I guess that, sorry, I want to repeat that question if you want.
Yeah, so it said that she rejected oral medication.
That's right, yeah.
And was injected instead. Was that not a red flag, and should they not have thought maybe there's something not right here?
So as I say, the assumption that this patient had a mental health illness, that pathway was the appropriate pathway. That's what you would normally experience in that situation. So no, it wasn't a red flag.
Can I ask on the subject of Nelson Hospital? I understand you're leading a response into that. Where are things at? What's the stage of that response?
Yes, so we are, obviously taking that very seriously, and I'm working with a group of my senior colleagues around a response to the many issues that have arisen. I've had a senior colleague down there yesterday, and others will be down there over the days and weeks ahead as we're looking at sort of 5 work streams to work alongside the team to address the issues that have been raised.
When were you first made aware of those issues?
Of the Nelson
The Nelson issues?
last week.
Was it through the media or was it through other?
So we, if I could frame it this way, in the context of a quality report that we put out last week, you'll see that in that we know we've got issues of access into our health system, issue into primary care, issue for surgery, for FSA. So we've been aware of those issues for a long time. And I guess we work with our local hospitals, our local leadership to address those and to try and help and support them as best we can. I guess the context of the Nelson is the multiple issues around patient care that have come up. I was aware of one of those cases for some time ago, but the other cases we weren't aware of, and so that's why we're sending in one of our team to go and look into what has been shown in the media and therefore what we need to do about it.
Obviously, it's quite concerning for the population down there. What's your message to the public who might be worried about what this means for health?
My message to the public is that Nelson Hospital, Nelson Bennett are great hospitals. They've got great staff and they deliver great care. We do have access concerns about getting to be seen in primary care. We do have concerns about patients getting access to see a specialist or to have their surgery. We're taking this very seriously. We are developing a plan to ensure that we can improve on those areas of concern.
How quickly do you hope to have that plan in place?
The plan, I would say a couple of weeks.
Just back on the incident with the 11-year-old, is anyone at a staff level being held to account yet for what's happened?
So our staff acted in good faith. They acted on the information they were provided, and they provided the care that you would provide in the circumstances they believed it was. So we are working with their staff. This is obviously incredibly distressing, as I've mentioned, to the young person, their family. Our staff, it's also distressing when they, discover the care they provided was due to misidentified space. So we're supporting our staff.
Are you able to say why it took until media inquiries, almost 2 weeks after the incident, that the government wasn't informed?
Yeah, so we've got 2 reports. You'll see the second one is an investigation into the escalation of that issue. And so the event that occurred on the 9th of March, on the 10th of March, it was entered into the district's electronic reporting system, and the Adverse Events Committee group met the following day to review that. It was escalated to many senior members within Health New Zealand and within the Ministry of Health, but through human error, it was not escalated up to the Ministry of Mental Health.
Right. And what would you say about speculation that staff at Waikato Hospital were trying to sweep this incident under the carpet?
So this is, the staff at Waikato Hospital took this seriously. They escalated appropriately within their system, and it got escalated up into senior health officials. It just didn't get to the Minister of Health.
Another of the recommendations is around reviewing the resourcing in that Waikato
That's right.
unit. Are you concerned there's not enough staff in that unit?
So we've undertaken what we call a rapid review. Normally in an event like this, we would undertake a much more thorough review, which would take several months, and we would interview a lot more staff than we've had time to do in this process. So through this process, questions have been asked about the resourcing, and so we think it's really important we look deeply into that and understand what that looks like and what changes may or may not be required.
Whereabouts in the mental health facility was she cared for? What type of room and what unit?
So she started in the ED, as you'll be aware, and then she was transferred to a mental health facility that had several different spaces. When it came to her being medicated, she was moved into a more intensive space. And you'll see that one of our recommendations is to review those policies around that, around how we manage the care and the appropriateness of treatment in those spaces.
So was she in one of the acute forensic spaces?
No.
And did she have other patients, the other adult patients there with her, either in the same room or in the same area?
I do not believe so.
There was aspect in the report about cultural, so I can't remember the exact language, but cultural appropriateness with care. Can you tell us what culture this child is from?
We wish not to disclose that in the context of privacy, but I think that what's really important from both cultural support and disability support, it's really important that our systems respond to that and that people who come into our services feel safe. Initially, cultural support was not provided. The focus was on the clinical presenting symptoms. Cultural support was provided once a transfer had occurred.
Is there any suggestion, or have you looked into whether her ethnicity could have played a part in her misidentification?
Yeah, I think that the misidentification, as we've talked about, occurred through the process, and the staff, I guess became or believed they were treating someone differently, and they treated that person appropriately based on what they had been led to believe.
You might have touched on this, but the first assessment of the young patient found that she may have had a disability and she was a young child. Was this only overlooked because police thought they'd identified her? Is that correct? Or?
So that's one of the learnings in the report, is that, as you say, that at the beginning she was, referred in, and it was under the emergency department rather than under the mental health team. At that time, those questions were asked. Then the misidentification occurred. She was put under another team, and there was an opportunity there where information could have been shared, and that may have led to a different outcome. So that's one of the learnings that we've found, and we plan to act on.
So will any staff be held to account over that? Or?
I don't think that's something to hold staff to account. I think that that's about the misidentification, and then a team picking up based on treating someone who they believe they were.
Was she put into seclusion at all?
I'm not sure what you mean by seclusion.
In the mental health facilities, sometimes patients are put into seclusion for a variety of reasons.
Not in an environment. We weren't. Although we were concerned about her mental health based on who we thought she were, we weren't. Concerned about. So I guess my answer would be no.
And yet we know that at Henry Bennett there have been cases where people have been cared for not in rooms, but in staff rooms or.
She wasn't in a staff. She wasn't in a staff room.
She had her own room.
Any further questions before we wrap up with Richard?
I guess my last question would be about the autistic community and whether people. What can you say to them after something? There's a lot of frightened parents out there. After something like this has happened, what could you say tomorrow if an autistic non-verbal child turned up in your ED?
That it's safe. It was really important to us to get this report out based on the needs of the young person, their family. But equally, as you'll see in our report, that it's important we work with our disability community, our cultural community, as part of the recommendations to make sure that we become a safer environment. So, this circumstance, as we've talked about, was unusual. That doesn't accept what happened at all, and as I say, we apologise for that.
Thanks everyone. There are some copies of the report just here by the door if anyone needed to pick up an extra copy, but thank you for coming today. Thanks.
Thank you.
Thank you.